I'm a psychologist advisor at Magellan Behavioral Health of PA. During today's webinar, please feel free to put questions and comments in the chat. You can also unmute yourself and ask questions. I will launch a few polls during the webinar. There will also be a post-test that'll be sent to you with a survey after the webinar for those who wish to receive continuing education credits. Okay, we're going to get started here. Okay, during this webinar, we'll review the reasons why it is necessary for all clinicians to be prepared to conduct suicide assessments and safety planning interventions. We'll discuss ethical considerations related to clinical standards for appropriate assessment and treatment. We'll discuss psychological factors associated with suicide risk. We'll review evidence-based suicide assessments utilizing 2 examples that support clinical decision-making. Finally, we'll discuss the importance of safety planning, including means restriction. At the conclusion of today's webinar, you should be able to describe the benefits of being prepared to assess suicidal risk. Understand the ethical considerations that underpin the need to be prepared to assess suicidal risk. Understand and assess psychological factors associated with suicidal risk. Be able to recognize evidence-based suicide risk assessment tools and know where to access information you may need to use them appropriately. Understand how an evidence-based risk assessment drives clinical decision-making, and understand the elements of safety planning and how to use them. This is my bio, which is just in here, and that you'll see with the copy. I almost forgot to mention, I'd ask everyone to please mute yourself unless you're coming off of mute to ask a question or make a comment. Okay, so here's a question, right? But before we get into this, I think we're going to launch a poll. How important is it to you to be knowledgeable about evidence-based suicide assessment and safety planning? So I'll take about a minute for anyone to please participate, as many people participate as possible. Is it unimportant, a top priority, or somewhere in between?
Hi, my submit button's not working. I chose my option, but when I hit submit, it's not an option for me to submit to the poll.
Yes, you have to keep scrolling down. It wants you to answer all 5
questions.
Yeah.
Oh, that makes sense. Thank you.
Yes, there's 5 questions. How confident are you in your knowledge of evidence-based suicide assessment and safety planning? How important is it to you to increase your readiness to implement evidence-based suicide assessment and safety planning with your next referral? How confident are you that you could competently and effectively provide evidence-based suicide assessment and safety planning with your next referral? Reasons that clinicians may not accept a referral to provide treatment to a person experiencing suicidal ideation include so it's kind of like that thing right now about, do you think you could land an airplane if the pilot got ill, except for the 5th question. But we'll give it 10 more seconds and then we'll see what our results have to say. Okay, I'm going to end the poll now. And we'll take a look at the results. Okay, well, It appears that everyone that participated feels that it's very important to be knowledgeable. It appears that just about everybody that participated feels pretty confident, which is good. And hopefully some of the information we share today will, clearly I think everybody's feeling like, well, I could be more confident, except for a few. How important is it to you to increase your readiness? Oh, I gotta love that one. And how confident are you that you could competently and effectively provide evidence-based suicide assessment and safety planning with your next referral? Oh, looks like people want to get more confident. That's good. And reasons that clinicians may not accept a referral. Right. So working with suicidal patients can be stressful and demanding. It may be threatening to one's professional identity as knowledgeable, competent, efficacious. It's impossible to control the patient's choices in an outpatient setting. And several people are concerned about getting sued because what if they commit suicide? Thank you very much for sharing that. Okay. So, is it possible to avoid treating persons with a risk of suicide? So, some research indicates that up to 50% of psychiatrists and 25% of psychologists will experience having a client complete a suicide either during or at some time during their life after they were in treatment. So one could certainly say that encountering suicidal patients might be unavoidable. We also see that during the pandemic that, we've seen a real spike in people presenting at the emergency room, both adults and adolescents with a suicidal ideation. So that certainly gets at the odds issue. Working with suicidal patients is stressful, demanding, and threatening. So it's a big concern. So, it's important to be ready when the challenge arises, because we're in this business to help people. And we want to be confident that we know when to talk about suicide, how to talk about it, so that we don't unnecessarily delay people getting access to the help they need with us. And there's a very high rate of individuals that go on to commit suicide after they start receiving mental health services. And we want to identify those individuals while they're receiving services and help them to not end their lives, to have a life worth living. Okay, let's do another poll. Okay, this is just one question. Barriers to clinician competence and confidence in assessment and treatment of suicidal risk include Now we'll just give this about 30 more seconds. Okay, I'm going to end the poll now, and we'll take a look at the results. Well, not surprisingly, almost 200 of our participants today identified at least one of these very significant concerns that people have and barriers. Yes, suicide focused treatment modalities are not taught during formal training. They may be starting to now, but most of us didn't get that. Mandatory annual agency training often focuses on increasing adherence to policy and procedure, which doesn't have to be a barrier if the policies and procedures include really clear step-by-step instructions about how to serve individuals in a suicidal crisis. But oftentimes, and we'll talk about this later, they may not. Clinicians may not be reimbursed for continuing education. You know, those of you on the front lines in community agencies may have limited resources for that. And, you know, you have to choose wisely. Clinicians may not know how to choose wisely about where to find high quality and even no cost training that could improve their ability to provide good suicide risk assessment and safety planning. Okay, now, but there's good news. You know, we can overcome these barriers because most of us have a genuine desire to help people get better. There are empirically supported treatments, and more, there are directives coming down from leadership and now going around with the counties with the Garrett Lee Smith grant initiative to really try and beef up everybody's training and skills in this area. And we don't want to lose a patient to suicide. So we go the extra mile. We don't want to get in litigation. And as we learn more about some of the issues with duty to care and reasonable care, we understand that we really need to know our stuff. Everybody else is maybe hearing other people talking about getting specialized training in this area, and you don't want to be the last one when the music stops. And when you see other people being successful in terms of making the correct call and getting people the help they need, you want to get in on that. We all do. So let's talk about why people commit suicide or attempt suicide. Okay, understanding the why of suicidal ideation and attempt is a key to effective intervention. Now, suicide is a highly complex and multifaceted phenomenon. Research suggests that there are cultural factors in why that have been found. But effective engagement of the patient is essential to understanding the why. We have interpersonal perception factors and external environmental factors that contribute to the members' risk for suicide. Engagement is best achieved when the patient and the clinician reach a shared understanding of the patient's suicidality. Now, this understanding is the basis of the therapeutic alliance. The clinician and the patient both bring a level of expertise to the therapeutic encounter. The clinician needs to be an expert on assessment and intervention. The patient is the only true expert about his or her suicidal experiences, and the therapeutic alliance allows the clinician to gain insight into the patient's experience, so they know what specific factors are driving this particular person's suicidal risk. So, some of the cultural differences that we've seen indicate that there are primary drivers across ethnic groups. The research suggests that external environmental factors are most endorsed by Latino and African Americans, and they least endorse interpersonal issues, as opposed to Asian Americans and whites, who most endorsed interpersonal perception issues and least endorsed external environmental issues. That's not to say that people don't endorse both across ethnic groups, but we see these as predominant factors. And one should be alert to that individuals identifying as BIPOC and Latinx have had experiences of discrimination and exclusion that they, the clinician may or may not have also experienced, and they may not be readily disclose unless the therapist asks. This may also be true of individuals identifying as LGBTQ+. Interpersonal factors may also be drivers for individuals who primarily endorse external environmental factors. So let's talk about three theories of suicidality that kind of address factors that contribute to the suicidal risk. The first is the cubic model, which looks at three interactive factors: external psychological factors, stressors, agitation, the impulse or desire to do something, and psychological pain, psychological or emotional pain. This figure shows how the three dimensions interact. The patient's experience of stress, psychological, emotional pain, and agitation, the urge to act, may be interrelated, and the cubic theory can be applied to individual assessment by asking the person to rate each of these dimensions. Efforts to reduce any one dimension under this theory are thought to reduce the risk of suicide. Hopelessness is another factor that's received a lot of research. Hopelessness is thought to reflect a cognitive style consisting of negative attributions about the future and one's helplessness to improve prospects for the future. In support of this perspective, several studies of non-psychotic populations suggest that assessment of hopelessness can help identify those at increased risk of suicide. Finally, self-regard or negative self-regard is an important factor to consider. This is less widely known than hopelessness, but this is an approach that was developed by Baumeister in 1990, where we see suicidal behavior as a drive to escape from unacceptable perceptions of self, kind of a self-hate perspective. Suicide is analyzed in terms of motivations to escape from adversive self-awareness. Okay, so ambivalence. Why is ambivalence important? Ambivalence is about the fact that when people show up for therapy and they indicate that they're suffering and they've been thinking about ending their lives, that you know that at least part of them wants to live. How do you know that? Well, you know that because they're in the session with you and that they haven't just gone and killed themselves. So ambivalence is a huge factor that needs to be addressed through treatment. And it is in large part the therapist friend, and needs to be leveraged in order to help the person identify and move towards increasing hopefulness about living what they would consider to be a life worth living and ending their suffering and being while living. So we always see it's important to remember the wish to die is opposed in the decisional balance by the wish to live. And we really need to know a lot about both. The tendency is, of course, in this situation, is we want to talk the person out of wanting to die. And we really want to have them talk themselves out of wanting to die. But before we can do that, we really have to understand why they want to die. We have to understand their suffering and have some empathy for why they might wish to die, considering their suffering. This is a necessary step towards engagement that can't be skipped. So we have to overcome our fear and have empathy with the person and their suffering, and not be afraid or give off signs or body language that we're uncomfortable with them talking about their crisis and the suffering that's led up to it. That's an essential part of the treatment and the assessment. Okay, so let's talk about standards of care. So there are two aspects of standards of care. One is the duty of care, and that involves the duty to attempt reasonably to prevent the suicide of the patient. Now, you don't have the power to prevent it. And we already saw that many of you acknowledged that one of the scary things about treating people in an outpatient setting is that you really can't control what they do between sessions. And it really requires our ongoing assessment of their ability to manage their safety between sessions. So, but we do have to take reasonable steps based on the assessment of risk. Okay. So the duty to care starts with an effective and evidence-based assessment of risk. And then we have the standard of care. And the standard of care is about the degree of skill and care customarily used in similar circumstances by similar clinicians. In other words, did we respond to the information about the assessment in a way that's consistent with what's considered the standard of care in our community? So, in other words, the duty of care is the responsibility to act affirmatively to protect the patient from their own violent actions, to the extent it's possible. The standard of care is established by judgment and opinion. Was the care provided reasonable, given the assessment of risk, not significantly or indefensively deviant from that of a reasonable professionals with similar training and experience? So, liability. Let's talk about this, get it out of the way, right? So, the two issues related to liability involve foreseeability, which has to do with to what extent could the risk have been foreseen? So in order to assess the risk in a way that people would say that there was an adequate effort to foresee the patient's risk, we need to ask about suicidal thoughts, plans, intent, actions they may have already taken, and risk factors that are associated with suicide. And reasonable care. Did the patient receive reasonable care? So the factors there include treatment is provided based on the available information. In other words, we did the assessment and we're guiding them to the treatment that's appropriate given the assessment information. And practice guidelines were followed that were reasonable and prudent care given the person's level of risk. So failing to address risk is an egregious professional failing on the part of the clinician. Because suicidal behavior is not predictable, the assessment of risk should be made and documented for all patients. Let me repeat that, for all patients. The assessment of risk involves at minimum questions about the suicidal thoughts, plans, intent, and actions, asking about known risk factors, and making a documentation of judgments, documenting judgments made about the basis of these observations. Here's a really big point that's really important. So like if you're scared, come off the ledge, because no one can be held liable for incorrect judgment unless it was formed on the basis of an egregious minimization of presented evidence. In other words, you can make the best possible assessment, provide the person with the appropriate treatment, and there is no guarantee they you've done your part. The patient has an undeniable part in the outcome of treatment related to suicidal ideation and suicidal intent. The important thing is to provide these appropriate assessments and treatment, or guide them to appropriate treatment, and document, not copiously, but not document, know what the important parts are to document. And you're going to learn that through this training, and make sure you do it, and do it that day, not go back and do it after something happens. Now, reasonable care connotes that the treatment plan has been developed that is consistent with the patient's diagnosis and assessed suicidal risk. For example, when the risk of suicide is elevated because of clinical depression, the treatment plan should include consideration of therapeutic and pharmacological interventions for depression. If the patient is judged to be at high or acute risk, precautions against the patient acting in some self-harming manner, potentially lethal self-harming manner, should be considered and attempted. So for instance, a high-risk patient cannot be sent home unmonitored and giving medications in sufficient quality to affect their death. These kinds of things have happened, and they need to, we need to take steps when we're in the position to see that those things don't happen. We need to look at what the patient's history is with adherence and non-adherence with recommendations for follow-up behavior. Okay, and the other important piece of this is dependable follow-through. So a component of reasonable care that specifically addresses the follow-through is, like, for example, following through to ensure, like, if a parent agreed to take the firearm out of the house, did you call and see did they actually do it? And if the parent agreed to take their adolescent to a psychiatric evaluation, or if the person agreed to follow through with the psychiatric evaluation, did they follow through with it? All right. If the clinician doesn't follow through and there's an adverse outcome, they can be held responsible, possibly. Well, certainly, I don't know whether they ultimately will be held responsible. It's hard to know, but the likelihood of being sued is going to be there. If the documentation reflects this level of follow through, the clinician's not an easy target. So some commonly alleged failures to meet standards of care are listed here. You can look at some of them and you can see that they're really things that could be easily avoided. And a lot of them are like, wow, how did that happen? But it happens. So we need to have a plan that we follow that doesn't open the door to liability. So either through lack of foreseeability or lack of causation. Okay, so competent risk assessment involves foreseeability, using empirically supported structured tools. We use screening tools at the onset of treatment and in-depth individual assessment as treatment progresses. So the PPA recommends a minimum of 3 questions for all clients. That's the Pennsylvania Psychological Association. Are you having suicidal thoughts? Have you thought about suicide in the past 2 months? Have you ever attempted suicide? Client answers yes to any of these questions, and more thorough assessments indicated. Now, we do have empirically tested screeners that can provide structure to the screening process that should be followed beyond the 3 questions recommended by PPA, and assesses behavior and intent of behavior. Other direct and indirect screening tools include items that assess suicidal ideation and intent. All right, and those assessments should be reviewed during the session they are completed. In-depth assessment that drives the treatment plan and progress monitoring can be used once treatment begins. Okay, so one of the things we need to assess that I mentioned is dynamic and static risk factors. related to suicide. So above is an incomplete list of historical and dynamic risk factors, or historical, also known as static risk factors, that can predict elevated risk based on past behavior and experiences. So the dynamic risk factors are amenable to change. Those are conditions that may exist in the present. So as I mentioned, these are incomplete lists. I would ask if you can think of a static risk factor not listed on this slide, please put it in the chat. Awesome. Okay. Now, can anyone think of a dynamic risk factor that's not listed on this slide? Please put that in the chat. Oh yeah, we're seeing some good ones. A lot of social determinants of health. Awesome. Thank you, everyone. Okay, now the 4 steps to risk assessment and risk management. Number 1, my favorite subject, not really, but it's one of my favorite subjects. So, do you have a suicide risk management specific policy and procedure? If you work in an agency, I would encourage you to inquire with your supervisor about that the next time you have supervision, or actually you should know where the policies and procedures are. You should go and look it up. And are your policies and procedures aligned with what you guys actually do every day? In other words, policies and procedures, not having one is bad. Having one that's not aligned with what would be best practices is worse. The worst thing is having one and not following it. So, do you assess all clients for suicide risk? Yes, someone put in the chat already. They beat me to it. Okay, what do you use for screening? What do you use for more in-depth assessment of risk? Okay, so once you're into treatment and you're working with a person and you're doing what I would call suicide-specific treatment, in other words, no matter what they came in for or whatever else is going on, whether they're depressed, anxious, have a personality disorder, have PTSD, when they're saying they're suicidal, the treatment is about decreasing the suicidal urge and the suicidal ideation. That's what it's about. And the other things are being treated as necessary, but the focus in the session is on decreasing the drivers for the suicidal intent, decreasing their stress, working with the person to help them be more confident that they can have a life worth living, and engagement. So during that process, it's ethically, clinically indicated to consult. For the obvious reasons that if you have a formal supervisor, you definitely want to consult and you want to document that consultation. Other factors include that there's always, I think, for everybody that is alive, experiences countertransference that has an effect on us when we're working with a person who is thinking about ending their life. It has the potential to interfere with engagement, and we need to talk about it with someone, with a colleague or a supervisor. Suicidal risk is difficult to assess sometimes difficult to experience empathy for a suicidal wish. And we really, as I mentioned, we need to be able to empathize with a person's desire to end their suffering, because it's about the treatment is about ending their suffering, but staying alive at the same time. So we can't like say, okay, I don't really want to talk too much about the suffering. Let's just worry about like signing a suicide contract and, and focusing on getting better. Can't not want to know and want to get in there with them in the wallow about their suffering. That is an essential part. So, we have feelings of lack of control between sessions, whether the person is going to make it or not. And then those of you who have been around for a while may have worked with a patient who has experienced chronic suicidal ideation. And that's when I make the comment there about suicide blackmail. That refers to a situation not where the patient is blackmailing you, but it's the patient that doesn't improve, or may improve a little bit, then slide back, and so forth. And that the therapist can come to feel like they're a prisoner of the case. And they may come to feel that, they become really kind of anxious. They start to think about, oh my gosh, this is redefining me in a negative way in my own mind as a therapist. And I'm feeling like an imposter and so forth. So that's a situation where consultation is really critical, because it really can affect clinical judgment and how you're managing the case and how you're working with the person. And all of these things, this consultation, it can reduce liability. It's going to help you avoid mistakes, and it's also going to support that in the negative, the event that there's a negative outcome, an attempt, or God forbid, a person dies of suicide, that there's strong documentation to indicate that you were reviewing what you were doing with the patient, and appropriately discussing the treatment plan and your work with the patient. And this is the stuff that is really important to do. It's important to do because it makes the treatment better, not just in case the worst thing possible happens. And then the suicide specific documentation, in terms of what specifically that you're doing, what is the treatment you're providing, and that needs to happen after the session, and it needs to be thorough. At some point in this training, I'm going to touch briefly on one example of a type of treatment documentation that works really well for this. Okay, so suicide-specific treatment. There's something called a step care model, which is the notion that we want to really be able to provide suicide-specific treatment for individuals that have high risk, moderate risk, and maybe not treatment that or risk that could be managed on an outpatient level versus more intensive levels of care. And we need to have tools in our toolkit that will work at the level of care where we're providing treatment. There are a number of evidence-based models that can be effective. And we'll go over some of those as we go along here. Okay, so evidence-based treatments for suicide include dialectical behavior therapy, cognitive therapy for suicide prevention, collaborative assessment and management of suicidality, and post-admission cognitive therapy. So DBT is been demonstrated primarily to be effective in decreasing self-harming behaviors, non-suicidal self-harm, but it's also very effective in working with patients that have suicidality is chronic with them, with some patients, and it's a better model for providing the supports and the treatment that they need to master that. Utilizes an acceptance focus when the patient feels misunderstood, and adopts a change focus when the patient needs motivation. Involves 3 components: skills training, strengthening of skills, and addressing barriers to motivation, and team consultation. Most studies demonstrating effectiveness are largely for female participants, not widely studied in males, which is something to consider. I think that I see the comment in the chat about EMDR. I'm not going to say that EMDR can't be effective in terms of studies of its effectiveness for suicidal thinking. In my search of the literature, I did not see any studies of significant size. That doesn't mean it doesn't work. I'm just saying that there haven't been large studies, certainly no randomized controlled studies looking at the effectiveness of EMDR for patients that have a history of suicide attempt or are presenting with suicidal ideation. So cognitive therapy for suicide prevention is evidence-based manualized cognitive behavioral treatment for adults and adolescents with suicidal ideation and behaviors. It was originally developed for individuals who recently attempted suicide. It's now being applied for individuals with acute suicidal ideation. It's based primarily on the assumption that individuals who are suicidal, who have attempted suicide, lack specific cognitive behavioral skills for coping effectively with suicidal crises. It targets the suicidal ideation and behavior directly. The CAMS model, my personal favorite, it's a phenomenological approach for understanding the patient's suicidality, which leads to suicide-specific treatment planning that emphasizes the use of an outpatient stabilization plan and the identification and treatment of patient-defined suicidal drivers. The number of sessions is determined by patients' progress in reducing suicidal ideation. The CAMS is a well-supported intervention for suicidal ideation for the Centers for Disease Control and meets the prevention criteria. Now, post-admission cognitive therapy is a brief intervention for psychiatric inpatients admitted after suicide attempts. So the primary outcome for this measure is days until repeat suicide attempt. It's been shown to be effective. Usually involves 3 sessions in the hospital of cognitive therapy. That's essentially the application of the cognitive therapy for suicide prevention model in the hospital setting. So, assessment of suicidal risk. Let's get back to this and get in a little bit more depth. So, high quality assessment tools are evidence-based. They assess ideation and behavior. They're low burden, in other words, they're easy to use. They have utility in many settings, and they guide decision-making on level of care. That's why some of us use the Columbia suicide scale, because it meets all those criteria. And it also, it's really important that that we use a tool that meets those criteria. So I'm going to show you a couple of tools here. And first, I'm going to launch a little poll and ask if any of you have used the Columbia, and if any of you have used the suicide status form, which I should show for the benefit of those who haven't used it. Thanks for putting those in the chat for me, Dana. Appreciate it. So the suicide assessment tools I'm displaying here are the Columbia Suicide Severity Rating Scale and the CAMS Suicide Status Form. I'm going to end the poll in about 10 seconds. Columbia Suicide Severity Rating Scale is the benchmark for suicide assessment for persons who are seeking mental health or behavioral health services. Okay, I'm going to share the results here. So clearly, more of us are familiar with the Columbia Suicide Severity Rating Scale, and then the CAMS Suicide Status Form, which is a more comprehensive treatment focused assessment that would be used in every treatment session. As I mentioned, Dana just dropped in the chat information where you can find these tools, where you can find information about how to use them. And, you know, I encourage you to pull that out of the chat and find some time to take a look at this. There's also a good video on challenges associated with assessment in adolescence through the Prevent Suicide PA Learning Collaborative on collecting valid data. There's a YouTube link there as well. So now, the Columbia Suicide Severity Rating Scale can be distinguished from screening tools designed for use in primary care settings, which I still hear a lot about folks using in clinical settings, such as the PHQ-9 or the also known as Patient Health Questionnaire 9. So the PHQ-9 is a depression is a depression module of the PRIME, and it scores each of the 9 DSM-5 criteria as 0, not at all, to 3 nearly every day, including one question: thoughts that you would be better off dead or hurting yourself in some way. You know, that's the only question related to suicidality. So when the suicidality question on the PH9 is answered with a 1, 2, or a 3, follow-up is required. So the same task, identifying the presence of suicidality, is accomplished by the Columbia, which is also free, with the first 2 questions, which have to do with, have you ever wished that you were dead, or wished you would go to sleep and not wake up? And then have you thought about suicide? That if you have a positive response to either one of those, that provides a structured format for a thorough assessment of the severity of the suicide ideation and the presence and severity of suicide behaviors. So why do 2 screeners when you can do 1 to accomplish the whole job? So when administering the Columbia Suicide Severity Rating Scale, the clinician should be alert for responses to questions 1 and 2 that are hesitant. Like, no, not really, which may be an indication that the patient is uncomfortable answering more accurately. Sensitive probing is indicated in those situations. Make eye contact. Don't be taking notes when you're asking these questions. Is really important. You might want to say, well, what thoughts are you having? You know, you're trying to help someone disclose something that may be very, very difficult for them to share for any number of reasons. So to question 3, or for question 3, have you been thinking about, so they've admitted, I've been thinking about killing myself. Have you been thinking about how you might do it? And they say, well, not really. Then again, I think you have to say, well, not really. So what kind of thoughts have you been having? Remember, revealing this information is difficult. So also we see on the right side here, the CAMS Suicide Status Form, 4th edition. And this one has been filled out by Dr. Jobs with his imaginary client, Kevin, which shows that what this first page of this suicide status form does, you may recognize some of these things. It's assessing all three dimensions of the cubic model, hopelessness, and also self-hate. It's also asking to what extent is the person feel like they are thinking that, you know, how they feel about themselves and about living, about their reasons for living, their reasons for dying, as well as what's the one thing that would make you not feel suicidal. The one thing question is really, really important, as well as the reasons for living in terms of identifying what the protective factors are here for this person. We really have to worry about folks that can't think of something that would make a difference. That's certainly part of an assessment of pretty significant risk. Okay, so let's talk about safety planning. So the old terminology, once you start working with a patient who is doing assessment, person, they've indicated that they have some suicidal wish, or they've thought about committing suicide, or they've had an attempt and they're thinking about doing it again. We used to talk about suicide contracts that were really were episodic, limited in scope, they're routine. We don't really think about it that way anymore. We think about safety planning. And the focus of safety planning is to be thinking globally about all the things that we can do to figure out how the patient can have supports around them at all times, the concept of a safety net. And so what should the safety plan include? Well, safety plan should include helping the person to understand the warning signs and triggers that are related to suicidal crisis or intensity of their suicidal ideation, internal coping strategies, who can help them remain safe, who can they call for help when they're in a crisis, who are the professionals that they can call if they need help in an emergency, and what can they do to make the environment safe, creating space and distance, time and distance between themselves and the means to harm themselves. So what is a safety plan? So it's a prioritized list of coping strategies. The patients have to be able to use these strategies during and before suicidal crisis. And safety planning is associated with reduced suicide attempts. In case you were wondering why I keep harping on suicide safety plans, that's why. So who should have a safety plan? Any patient who has a suicidal crisis should have a comprehensive safety plan. And the clinician should collaborate, what I talked about before, about forming the therapeutic alliance and developing the plan. So how should it be done? Okay, I'm not talking about the safety plan that is like in all the documents that you guys do with every patient, where it's like, if you have a problem, you call 911. Yeah, it's all the stuff before that the patient works with you on, what they're going to do collaboratively, how they're going to be involved in it, not what other people are going to do if they say, I want to kill myself, although that might be part of it. So again, it involves listening and empathizing and engaging the patient to understand the events surrounding suicidal crises for them so that they can think about what they can do to try and keep themselves safe. So there are 6 steps involved in the development of a good safety plan, and we're going to base this off of the Stanley Brown safety planning intervention. Okay, now the Stanley Brown safety planning intervention is based on the notion that suicidal crisis may be relatively short-lived. And an intervention that assists patients with coping with such crises may be particularly useful even if the intervention is only used for a brief period of time until the crisis diminishes. It's like, if any of you have ever tried to quit smoking, they used to tell you stuff like, go take a shower, things that are incompatible with doing the thing you're trying not to do. So I think I'm going to ask Dana to drop some stuff in the chat here on the Stanley Brown safety planning intervention.
John, what you had sent me was duplicated from Sam's model. So I don't know if you can send that to me and I'll throw it in the chat, or if you just want me to include it in the email that I send out with all the other information.
Yeah, I'm gonna do that because
Okay.
I can't. One of the problems with I'm
No
not able to
worries.
do it.
I'll include it in the email, so it'll be
Okay.
on its way shortly.
So it's the cool thing about this this safety plan, it's a standalone. In other words, it's not enough. Like, you can't just do the safety plan and no treatment, but it's a bridge. And it has been shown in and of itself to be a valuable tool. The information you're going to get is the link to get the safety plan, and then most importantly, a 1-hour video of Dr. Barbara Stanley talking about it and how to use it, not only with easy patients, but the patients that might present a challenge. So, systematic and comprehensive approach to maintaining safety. That's what we want. Patients are given tools that they can use. That's so, with some patients, they really would benefit from having this, and they get to take the safety plan with them at the end of the planning, make a copy, and they take it with them. Includes means restriction and emergency contacts, and utilizes internal coping strategies and distracting strategies. All right, so now during the risk assessment, the safety plan intervention can take about 20 to 45 minutes, depending on how complicated the situation is. So in order to do it right, the clinician during the risk assessment has to obtain an accurate account of the events that transpired before, during, and after the recent suicidal crisis. Patients typically are asked to describe the crisis, including the precipitating events and their reactions. This review of the crisis facilitates the identification of warning signs to be included in the safety plan and helps to build rapport because of the empathy that we show to the patient in that situation, that they don't have to be ashamed, that we have positive regard for them and care about them. Many individuals who are experiencing suicide risk, like many other individuals that we work with, may have difficulty in interpersonal situations. So clinicians should be prepared for the possibility that hearing a person's suicidal crisis story may provoke emotional reactions from us, and that it may be hard for them to tell the story for reasons related to their difficulty, talking with other people. It's important to pay close attention to one's own emotional reactions and our own expressions, because even ambiguous responses from us could be misinterpreted. So we really have to focus on, projecting our warmth and our empathy. So it's our ability to demonstrate empathy to the patient's suffering that will help to set their expectation for compassionate care throughout their treatment process. Your capacity to demonstrate engagement while the person shares their suicidal crisis experience may help to overcome whatever negative expectations they have about sharing their suffering and the stressors that have led them to consider ending their lives. It may be important to remind the patient, especially adolescents and young adults, that many people suffering with similar problems think about suicide. Reflect and ask questions about what happened before or what happened next to help the patient recognize that you're engaged and listening, and to help them generate the narrative that we need in order to build a safety plan. So the collaborative stance, as I mentioned before, is really essential to developing enough information about the suicidal crisis to make this an individualized plan, which is what the goal is. That's the only way it has a chance of working. So implementing the plan, right? So I want to spend some time on this before we go to questions. So step one, we're looking at helping the person identify warning signs. So you're going to be asking stuff like, so how will you know when the safety plan should be used? Right? What do you experience when you start to think about suicide or feel extremely depressed? You know, what thoughts are you having? What sort of situations are you in when that kind of thing occurs? You know, people, places, and things, warning signs, thoughts, images, thinking processes, moods, in their own words, right? Because they're going to take this with them. Internal coping strategies. So we want to be asking, what can you do on your own if you become suicidal again to help yourself not act on your thoughts or urges? Now, this step may become more meaningful as treatment proceeds because the safety plan is going to be revised as treatment goes on. It's going to be looked at in every session, and as part of every session to think about what can we build on, what can we add to it, what isn't working, what do we need to change. So at the front end, it may be that there may not be a lot of internal coping strategies that the person can identify, but we still want to ask, what can you do? Are there any things that have ever worked that we'd want to try? You know, assess the likelihood of use. So if they throw something out there because maybe they're trying to be a good patient and like say what they think you want to hear, you got to say, so how likely would you think it would be that you would do this during a time of crisis? And you know, really kind of be accepting of whatever their answer is. If doubt about use is expressed, what might stand in your way? You know, they might say, well, doctor, I just don't think when I'm in that mood. Be like, okay. So see if there's any way that we can work with that in that session, or we might just want to say we're going to go right to step 3. So step 3 is really important. So it's like, what social contacts do we have or things we can do that might distract ourselves to get us to stop thinking about it? It's not the same thing as internal coping skills. So you would tell the person to use step 3 if step 2 doesn't resolve the crisis or lower their risk. Who or what social settings might help you take your mind off the problem, at least for a little while? Because, you know, that's always what it's about. It's about for a little while, not forever, but distractions like for a little while. Who helps you feel better? So this isn't like, who can I call up and say, I feel like killing myself. Can you help me? No, that's not this step. That's like, who could I talk to where they could just take my mind off it and we could just, you know, have a nice conversation? Or who could meet me for a cup of coffee? Or could I just go for a cup of coffee? Could I go for a walk? What are safe places you can go to be around people? Places where, again, you're putting time and distance between the person and the means, and putting them in a place where they're not going to act on their suicidal thoughts. Ask people to list several people in social settings in case the first option isn't available. And the goal is distraction. Assess the likelihood that the person would engage in this step. Try and identify potential barriers, problem solve as appropriate. So then sometimes they're going to say that you're not going to feel like step 3 is going to work. Then you go to step 4. Among your family and friends, who do you think you could contact for help during a crisis? Now, this is a person you could say, I'm really struggling today. Can I come over? Can you come and spend time with me? It's not a good time for me to be alone. Or can you talk to me? Or can you check on me? Or whatever. So you want the person to identify those individuals. Hopefully there's at least one person who they can rely on in this regard. Hopefully two. Ask patients to list several people in case the first one isn't available. Just like in AA, you have a phone list. You don't just have a sponsor. It's like, well, I couldn't reach my sponsor. We'll pick up the phone, call somebody else. Same kind of concept. So we want to assess the likelihood again that they'll engage in this step. Can they think of any barriers? What might get in their way? How could they get around that? This is one where you might want to role play and rehearse, because some people will get kind of tongue-tied, and if they haven't done this before, reached out to someone, like, so how would I let somebody know that I might want to reach out for help with this? How would I have that conversation with them? So that would be something that would be role played in the session to make sure the person knew what to do, so that becoming tongue-tied or becoming shameful or embarrassed wouldn't prevent them from doing it. So then it's our turn in step 5. Who's the clinician, right? And who are healthcare providers that, again, suppose you're just doing the assessment and you won't be completing the treatment. Who are you seeing, or who could you call if, steps 2, 3, 4 haven't worked? Get their names, numbers, locations, location of urgent care services or crisis centers. You want to make sure that they write the 988 number down there and assess the likelihood that they'll use this. Now, an important thing to note here is that, especially for persons that don't have a lot of informal supports, when you say, I want you to call 988, if you're really struggling between the sessions, and they say, well, why would I call crisis session? I have you, Dr. Sigler. And I'd say, well, you're only seeing me like maybe once or twice a week. If this number is there for you to call. So if you're struggling, there's somebody there that'll talk to you and try and help you, work, some of these other steps and help you to calm down, distract you, figure out if you need to go to step 6 or not. And it's okay. In fact, at times with some patients, you want to have them, take out their phone and call 988 just to see that they can do it. And again, role play and rehearsal about how they would do that in between sessions is helpful. So final step, and this is really kind of key. With a lot of people, I'm not going to argue with Dr. Stanley, but for me, I'm like, this is step 1. All right. You making the environment safe, right? Ask the patient what means they might consider using during a suicidal crisis. That's important, right? But then regardless of what they say, whether they say hang myself with a bait, with a belt, cut myself with a razor, you're still going to ask, do you own a firearm? And why do you ask that, do you suppose? We ask that because the firearm is the means used in most suicide deaths. And we also want to ask them about medication as well, right? Because medication is the means used in most suicide attempts. So even though they have something in mind, we also want to ask about these other 2 means, and to see whether they would be able to collaboratively identify ways they could decrease their access to those kind of means. How could we go about developing a plan to limit your access to those means? Now, with adolescents, obviously, or maybe it's not obvious, we really have to be involving parents in that discussion, or caregivers. And sometimes the discussion can be a little dicey Depending on how accepting the parents are of some of the suicidal drivers, I think the one that comes to mind the most is, issues with kids that are transgender where the parents aren't accepting, and they're, thinking that the suicidal crisis is, a play for attention or sympathy. And if that person also is someone who owns a firearm for protection, they'd be like, what are we talking about my handgun when they cut their arm? And that can be a tough conversation, but it's a conversation that's really important to have because most parents will identify that if they keep a gun for protection, that they have to protect their family. And we've got to enlarge that circle to say, well, whatever you're feeling about your child's current gender, feeling about what their gender is, or how seriously you take their suicidal crisis, keeping your child alive is certainly part of protecting your family. So to be on the safe side, because if something happened, you would, how would you feel? Maybe they wouldn't even have done it on purpose, but then how would we feel? What steps can we take to make sure that something unthinkable can't happen until we get through this, which won't be forever? So these are important conversations to have with parents. I naturally want to document the outcome of those in terms of what the parents have agreed to do. And what's that thing that I said way back when about dependable what? After you've made a plan about how the parents are going to support their adolescent treatment, what are you going to do? You're going to follow through. Thank you. Exactly. You're going to check and make sure. So that's the end of my presentation at this point. Happy to entertain questions and or comments. Anyone who'd like to come off mute. I'm also going back through the chat now. I do see. Go ahead.
So I had a question. So one of my clients said that her method of killing herself would be for her to throw herself out of the window. And so I have like more supervision, like lock window, make sure for mom to make sure like the windows are locked. But like, what else could she do? Because she can't afford to like put bars on the windows or anything like that. Or so like what other like home safety methods could she produce?
Mm-hmm. I guess, is this an adolescent?
Yes.
Okay. And what do they live on the first floor, second floor, third floor?
They live in a regular house. Her room is on the second floor.
Okay. So but the parents are working with you collaboratively for supervision?
Yeah, so the mom said that she can like look in her room more, like to check
Mhm.
on her, because she said she kind of like does like leave her alone because she feel like that's what she needs and wants. But she said with the plan she'll like do like check in her room like every half an hour or so just to like look in or listen out for what she's doing inside the room.
Yeah, well, I mean, this isn't a 2-minuter, but I think you've talked about some of the things you've already done, and then it's the ongoing assessment of the adolescents, first their engagement in their own safety. Is the adolescent willing to let the parent know if they're feeling suicidal or feeling the urge to hurt themselves?
Right.
So mom, I'll tell you, right? Has the parent talked with you about the situations that for that adolescent seem to be associated with self, self-injurious behavior or self-directed violence, or when the threats are made, what's going on. So that can be avoided, or that interaction can be changed. And then it's at the point where the parent feels like this ain't working, then are they in agreement to let you know that, so that you can work with them about if you need to do more.
Okay, yeah, because I was just thinking, I'm like, well, like, even if the windows are locked, like, she could, go through the glass if she wanted to,
if she wanted to, that's right. So it, even when you need to work with the parent around the ways they can support the adolescent, and it's all about engaging the adolescent in figuring out a way to decrease their suffering and to help them. A lot of times it's like how to do some better problem solving around the stuff that's really making them suffer, and keeping them alive in the meantime. But it's their responsibility to identify persons that in their safety plan that they can utilize for distraction and for support if they need it. So those are things you got to work with the parent, what the parent will agree to in terms of what's acceptable to them in terms of the safety plan. And then most important, if the parent's like, okay, I'm done with this. Nope, this isn't working, that they agree in writing that they'll let you know when they're done doing it your way, so to speak. So then you have the opportunity to say, okay, what's going on? What are our next steps? Because that's where things go off the rail, right? Is that it's hard for a parent in that situation, right? To be supervising their child and wanting to know how long this is going to go on. And they make a commitment to follow a certain set of steps or follow a certain set of advice from you, but it's not forever.
Right.
It's like until it works or until they get tired of it.
Right.
So the idea is that we're going to be successful in engaging the kid, and the kid's risk level is going to go down. In a case where that doesn't happen for whatever reason that we don't know, we want a commitment for the parent that they'll let us know when they're done.
Right. Okay. That makes sense.
Because that's when things can spike.
John, there is another question in the chat.
Oh, great.
Do you have any recommendations for suicide screening tools for younger children aside from the pediatric version of the Columbia?
I don't. What I would suggest in that situation is that you can use the Columbia as a guide. You're going to want to involve the parent or the caregiver in the assessment at that point. They're usually already involved because the child is saying, which is also unusual. It's less unusual than it used to be, but it's more unusual than older kids or adolescents. And you can ask the questions to the parent as well. What are they seeing? What are they hearing? Because a lot of times for younger kids, when you say, so have you thought about, have you wished you were dead in the past month? What's the past month to an 11-year-old? That's like the same thing as now, right? Or today. That doesn't work for them. The parent, on the other hand, might say, you should have been here, 2 days ago. That's what you have to do. You have to use it as a guide, but involve the parent as well. Parents are really involved. The younger the kid, the more important the parent is involved in the means restriction part of the safety plan. And the more important it is to make sure that we're looking at all lethal means, not just the thing that the kid may have been doing, or if there was an attempt or a gesture, but the gun, medication, got to have a plan for that, because younger kids, they act impulsively, and then you can't take it back. You can't undo it. So again, sometimes thorny conversations with parents, but those are the questions that need to be asked. And for the child is giving you a lot of or no, to know that at that developmental age, what you might reasonably expect from the child. And then you ask the parent and or other people that know the parent well in the context where the suicidal behavior or the suicidal threats are occurring.
Okay. So I have another question. So I did assessment. I did a plan with a family, and they said like that they didn't have anyone. Like they had no one in the schools. They had no family members. So like the part where it's like, who else could you call? Like she had nobody. Like what place could you go? She like, I only have like my room, like that's it. Like I don't have any place in school because she's homeschooled. So she and she had no peers, no aunts, no
How did the parents feel about her
teachers,
calling?
counselors.
How did the parents feel about her calling 988?
What do you mean 988?
Oh, that's the crisis line. So like if she doesn't have
So
anybody else to talk to and she doesn't want to talk to her parents.
okay, so nope, I didn't ask that. So I did give them the crisis hotline number for emergencies, but I didn't say like, oh,
Yeah.
it's not only for emergencies. You could call just if you're feeling bad. I didn't give her that advice, but because I didn't know that either.
Yeah, it's not just like bring the ambulance. It's like I'm struggling, and they're trained counselors in 13 PA crisis centers that can provide immediate phone-based support.
Okay, all right, that's good to know. I'm
John,
gonna
we,
screenshot that.
Yes.
yes, and I'll send those slides too, so you'll have it there as well. We have 3 minutes and 2
Okay.
more questions. Do you think you can
Yes.
for those? Okay.
Let's do it.
The first question is, what can you say to a parent who has a child who self-harms? This parent finds it hard to parent the youth because they're fearful that it will push the youth to again self-harm.
Well, and I only have 1 minute because we have 2 other questions, right?
One more question, so you can take a minute.
Okay. Oh man. Okay. So I think we got to talk about that as being pretty serious situation. I think there has to be an assessment of the kid in terms of to make sure that there isn't some part of this behavior that is a wish to die, or whether the intention of the behavior is entirely to influence the parent or to feel something or some other reason. You have to make sure that it's not somewhat of an expression of suicidal intent. If it is, then it needs to be treated as such. I think means restriction can become a power struggle, but there needs to be some engagement with the therapist, with the child, about what's going on with them that they feel like they need to do that, and how can we come up with a better another way for them to meet the function of the cutting behavior.
Thank you. And the last question is, as a school counselor, we often have individuals returning from inpatient settings without discharge summaries. No knowledge of a safety plan has been developed, but we're highly involved with the support. Any advice to close this communication gap?
I'm on calls like every week about this. Yeah, I've just counselors say, yes, so-and-so disappeared. And then a week later, they showed back up at school and they said they'd been in the hospital, and we have nothing. In that situation, it's generally that the case that the hospital social worker is supposed to notify the school. Unfortunately, that can take the form of a voicemail, and it may not occur until discharge or after. If the child will share with you information about where they were in the hospital, you just have to go through them or the parent and try and get that information. We're trying to work on increasing collaboration across systems in this area, and that's certainly at the top of the list. That's all I can offer you at this time.
Thanks, John. And thanks everyone for joining today. I did put the post-test in the chat. I will also be sending the post-test link out with the slides within the next 24 hours. The post-test survey does need to be completed by April 6th to receive your certificates. Someone asked a question. We are going to have a part 2 of this training that will most likely be presented in June, and we'll make sure to disseminate all of those promotional materials within the upcoming months. Thanks for joining, everyone.